You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for January 7th, 2022. This week, sudden death causes, Inclisiran, DOAC choices, and alcohol intake and ventricular arrhythmias. First, I want to say Happy New Year and again express my thanks for listening to TWIC. What a start we've had to this year and the Omicron surge. Now, the old John would have opined briefly on this. The new John, however, has decided that A, no one is persuaded by any pandemic-related commentary, B, everything pandemic-related is politically charged and too dangerous to speak on, and C, it's best to move straight to cardiology topics. So let's talk about sudden cardiac death. Now, one thing we electrophysiologists tend to forget, me included, is that nearly all patients whom we implant pacers and ICDs in end up dying with them. Well, sometimes the cause of death in these patients is obvious, cancer and heart failure and pneumonia. But sudden and unexplained death is common, and nearly all of these modern devices have the capability of detecting arrhythmias. So there's a bunch of learning to be had in these cases. The Melbourne, Australia EP group has published a very nice paper in JACC EP chronicling a 15-year experience looking at post-mortem interrogation of cardiac devices. Now, these were pacers, ICDs, and loop recorders. The sample size was 260 patients, median age 73. After the autopsy, about 7 in 10 of these deaths were deemed cardiac-related. The interrogation directly informed the cause of death in half the cases. VT or VF was the terminal rhythm in nearly half the group and was more common in ICD patients than pacers. None of the ILR patients had VT-VF as the terminal rhythm, and I say thank goodness, since we often implant these devices for syncope. Only 10% of the patients who died from VT-VF had non-sustained VT in the 30 days before death, and I'll come back to that. One of the key findings was that potential device malfunction was seen in 8%, nearly 1 in 10. These issues included failure to appropriately treat ventricular arrhythmias, lead issues, or battery depletion. Of the 13 cases identified to have potential undertreatment of ventricular arrhythmias, 2 devices had major technical issues identified due to faulty leads for which a recall had been issued. 6 had not appropriately recognized a ventricular arrhythmia and therefore withheld defibrillation. And 5 had appropriately withheld therapy as the VT was at a rate below the designated therapy set by the treating cardiologist. Now, in several cases, the absence of an arrhythmia carried medical legal implications. For example, in 8 fatal motor vehicle accidents, only 1 patient had a ventricular arrhythmia documented on their device. Now, my comments, these are really important findings. Device malfunction was directly implicated in 3 people, and in 6, there was concern regarding misrecognition of rhythm. Well, this finding of device malfunction as a cause of death has been described by German and UCSF teams, and I will link to those papers. But here's why these observations are important. There is this notion that ICDs are near perfect and require little maintenance. Neither of those things are true. I think the best way to mitigate these problems is laser-like focus on programming and follow-up. Much attention is focused on the implant decision and then the implant procedure, but arguably, these are the easy parts. I think it's almost as if we need a timeout for programming as much as we do preoperatively. Patients with cardiac devices should understand going into the procedure the importance of follow-up, especially remote follow-up. I also strongly believe in a medically conservative approach to hardware choices. Now, as a younger doc, I was totally burned by the Sprint Fidelis disaster, and that's because we were all wooed by the new technology. I now use tried and true leads. There are performance reports, and there are leads that have proven performance. I stand by those leads. Math professor Nassim Taleb calls it the Lindy effect, named after a deli that has withstood the test of time. The second important observation was the lack of significant pre-mortem abnormalities, which is highly notable because this is a population enriched for having heart disease and high risk. I was struck by the fact that only 10% who died from VTVF had non-sustained VT in the 30 days before death. In other words, 90% of patients who died from VTVF had no non-sustained VT in the month before death. Only one patient had a shock for VTVF in the 30 days before. Now, this lack of signal has implications for the move towards more monitoring. Remote monitoring may be great for detecting lead and device malfunction, but it seems less likely to improve outcomes from finding warning arrhythmias, of which there seems to be little, at least from this paper. Now, the corollary here is the deluge of messages that cardiologists receive regarding non-sustained VT in patients with these devices. I mean, right now, these self-terminating arrhythmias instill quite a bit of fear, and fear means stress testing, echoes, and then CAS. Studies like these make me wonder how much non-sustained VT, and for that matter, how much non-sustained short-lived AFib is actually quote-unquote normal in these patients. I sense that a lot of these non-sustained ventricular and atrial arrhythmias are expected and also non-risk stratifying. My final comment on this important paper is on the issue of subcutaneous ICD versus transvenous ICD. This study looked at transvenous ICDs. Sub-Q ICDs have higher DFTs and more difficulty with sensing, and I think it will be very important to do similar postmortem analysis in anyone with an SICD that dies suddenly. Next topic is Inclisiran. Just before Christmas, FDA approved Inclisiran as an adjunct to statin therapy for further reduction of LDL cholesterol. Inclisiran is a first-in-class small interfering RNA agent. Now, not only is it a novel drug type, but it's also novel in its delivery, as it is given by sub-Q injection initially, then in 3 months, and then every 6 months thereafter. The drug works by silencing RNA involved in making the PCSK9 molecule, which has a role in controlling the number of LDL cholesterol receptors. The indication here is for patients on maximally tolerated statins who have known heart disease or heterozygous familial hypercholesterolemia who require additional LDL cholesterol reduction. The approval is based on the 3 Orion clinical trials. These trials, Orion 9 of heterozygous FH patients and Orion 10 and 11 of patients with atherosclerotic vascular disease or risk equivalent patients, all showed LDL cholesterol reductions of about 50%. Some interesting tidbits. Peak plasma levels of Inclisiran occur approximately 4 hours after the dose, and most of the drug is excreted through the kidney. After uptake, the drug is bound to the RNA-inducing silencing complex in liver cell cytoplasm. Inclisiran is no longer detectable in plasma within 24 to 48 hours of dosing. So a theoretical concern is that any adverse effects are staying a while because the LDL lowering effect decays very slowly over months. But the authors of the Orion papers write that the trials included thousands of injections and person years of exposure, and adverse events were similar. As for cardiac events, you all want to know about cardiac events. The 3 trials had as their primary endpoint LDL cholesterol reduction, which regular listeners of TWIC know is merely a surrogate marker for cardiac events. Cardiac events were actually lower in the Inclisiran arm of these trials, but the authors rightly say that there were too few events to make any meaningful conclusions about outcomes. Now, my comments. My first thought, it was peculiar that FDA approved a novel drug based solely on LDL cholesterol reduction, but this is probably because FDA considers LDL a reliable enough surrogate marker to give market approval based on that. Also, in the American Journal of Cardiology published in 2020, and I'll link to it, there's a meta-analysis of the 3 Orion trials with about 3,600 patients, which found a 24% reduction in CV events The 24% reduction had a risk ratio of 0.76, confidence interval 0.61 to 0.92. That same meta-analysis also found no signal of adverse events when they combined the data from the 3 trials. Now, the Orion 4 trial is an outcomes trial enrolling patients now in Inclisiran versus placebo. It's scheduled to enroll about 15,000 patients. Now, while all these signals look good and LDL cholesterol is a strong surrogate, no patient ever complains about a cholesterol level. They are interested in reduced MI, strokes, and death. These are the patient-centered outcomes. And in practice, really, FDA approval of the drug may not matter much because it will be costly, and until there are outcomes benefits, insurers seem unlikely to cover it. But if Orion 4 delivers even mildly improved CV outcomes, the every 6-month delivery will be hard to beat. Plus, remember, friends, it's not a high bar to beat evolocumab and alirocumab, as the hazard ratio in Foyer and Odyssey were only about 0.85 or a 15% reduction in non-fatal outcomes. And there's a bit of a race going on here. Merck has an oral PCSK9 inhibitor in development. Phase 1 data was presented at AHA, and it was favorable, but Inclisiran outcomes will be way ahead of it. Finally, it has been a long time since I've been in a molecular biology class, but this sure seems like a remarkable scientific advance. It's pretty darn cool. All right, next topic, DOAC choices and the perils of observational comparisons. The choice of a direct-acting oral anticoagulant comes up often, and I don't know about your practice, but for me, it's apixaban or rivaroxaban. I haven't started a dabigatran prescription in years. Patients often ask which of the 2 DOACs are best, and both drugs were tested in non-inferiority trials against warfarin, and both drugs proved non-inferior to warfarin for stroke and systemic embolism. They've never been compared to head-to-head in an RCT. Now, many of us think apixaban is the superior agent because the point estimates of the hazard ratio for apixaban versus warfarin looked better than rivaroxaban versus warfarin. And since the pharmacokinetics are pretty similar, apixaban's twice-daily dosing seems to make more sense. But here's the thing. The trials enrolled different types of patients, were carried in different centers, and we should never, ever, ever discount the real-world value of once-daily dosing over twice-daily dosing. And this is likely why prasugrel crushed ticagrelor in the ISAR REACT 5 trial. Now, recently, Vanderbilt authors have published in JAMA a comparison of the 2 drugs. And you may wonder, did they randomize tens of thousands of patients? The answer is no. They harnessed a U.S. Medicare claims database and performed a retrospective cohort study of 581,000 patients with AFib who a clinician chose to give either rivaroxaban or apixaban to. And they found the adjusted primary outcome of major ischemic stroke, systemic embolism, and hemorrhagic intracranial bleeding rate for rivaroxaban was 16.1 per 1,000 patient years versus 13.4 per 1,000 patient years apixaban. The risk difference was 2.7 per 1,000 patient years, and the hazard ratio was 1.18, with the confidence intervals ranging from 1.12 to 1.24. In other words, rivaroxaban was 18% worse. In fact, for every outcome, rivaroxaban looks slightly better in the adjusted outcomes. The authors did tons of adjustments in sensitivity analysis. This included adjustments for, get this, 208 covariates, such as demographic factors, clinical features like diabetes or no diabetes, measures of frailty, etc. But then the authors wrote this in the first line of the limitations, quote, residual confounding by unmeasured factors, including geographic variation in the preference of patients and physicians, is possible, end quote. Now, there's also the matter of misclassification of outcomes that's inherent in claims data, and the matter of those who discontinued therapy, but I want to focus on the non-randomized issue. My friends, we have discussed this many times. No matter how many variables you control for, you can only control for those that are on the spreadsheet. Tons more factors go into a clinician's decision to use one drug or another. Therefore, if you want to draw causal conclusions from a comparison of 2 drugs, you need randomization to balance out the measured and unmeasured covariates. You simply cannot make conclusions from this sort of data. Yes, you can use the priors from the DOAC versus warfarin trials, and you can consider the pharmacokinetic data. So it's plausible that apixaban is better than rivaroxaban, but you can't discern it without randomization. And I would say don't be persuaded by the 580,000 patients. Large numbers do not mitigate bias from confounding. In fact, it may worsen it. Though I don't think you need any more, perhaps you want more than residual confounding so that you can ignore these findings. Here is another clue. As pointed out by Dr. Manesh Patel in the news coverage, Dr. Patel noted that the unadjusted rates of events favored rivaroxaban and apixaban came out ahead only after adjustments. Now, the good news is that a little birdie told me at a recent conference that there may be a large-scale randomized trial being conceived comparing these two drugs. That, my friends, is the only way to tell. Now, think about this. You could actually embed randomization into an electronic health record. For now, both these drugs have utility. I truly don't know if there is a difference. Every time I prescribe apixaban, thinking it may be better, I remember how many times I forget to take the second dose of my asthma puffer, and I have symptomatic wheezing. Never discount the value of once daily dosing. Final topic today is on alcohol and ventricular arrhythmias. The Adelaide group published in Heart Rhythm Journal the results of an observational study of just over 400,000 individuals from the UK Biobank, and they looked at the association of total and beverage-specific intake of alcohol with ventricular arrhythmias and sudden cardiac death events. Now, first a note on the UK Biobank. This is a rich source of observational data. It is a prospective cohort of about 500,000 individuals aged 40 to 69 across the UK. These individuals were recruited from assessment centers between 2006 and 2010. They completed a questionnaire, and they had basic anthropomorphic measurements made. Interviews were done to assess comorbidities, and then researchers can use death and hospital records to assess outcomes. Now, the knock on the UK Biobank is that it might suffer from healthy volunteer effect, therefore may not be generalizable to the population as a whole. The main findings of this study were: 1, there was no clear association with total alcohol consumption and incident ventricular arrhythmias. However, the consumption of a greater amount of spirits did seem to associate with a slightly increased ventricular arrhythmia risk. 2nd, they found a U-shaped association for total alcohol consumption and sudden death risk. Now, U-shaped means intake of low amounts of alcohol looked protective, lower sudden death risk. 3rd finding, beverage-specific analyses of the sudden death risk delivered contrasting results. Individuals who had high intake of beer, cider, and spirits had a higher risk of sudden cardiac death than individuals who drank red and white wine. And they found no substantial association of interaction between alcohol and sex for ventricular arrhythmias and sudden cardiac death. Now, we learn in the discussion section that while there is a ton of data on alcohol and AFib, there hasn't been a lot of data published on alcohol and ventricular arrhythmias. So the main finding to discuss here is that you'd think alcohol would have the same relationship with ventricular arrhythmias and sudden cardiac death, but there was no real association with ventricular arrhythmias, but a U-shaped protective effect at low doses for sudden cardiac death. I think I agree with the authors who write that there is limited specificity in sudden cardiac death diagnoses for a fatal event. They cite the UCSF autopsy study I mentioned earlier, which found that up to 40% of all sudden cardiac death was confirmed as non-arrhythmic in origin. Now, the beverage-specific contrasting associations with sudden cardiac death are a novel finding, but it's hard, I think, to sort out causality here because it's clearly possible that people who drink lots of beer and spirits may materially differ from patients who drink white wine, for instance. I think this paper is a good first step in understanding the relationship of alcohol and ventricular arrhythmia, and it seems to further reinforce the crucially important concept that toxicity is in large part a matter of dosage. So that's it for this week in cardiology. As always, I'm grateful that you listened. And remember, if you like this podcast, please take the time to give us a rating, write us a 1 or 2 sentence review, and remember there's a comment section on the heart.org Medscape Cardiology where if you disagree or have a point to make, please do so in the comments there. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.